Hello class, today's topic is on thrombosis. So, continuing with hemodynamic disorders, we will start with a very important topic known as thrombosis, and the competency is 6.4 and these are the various learning objectives. So, in this class you are going to define what is normal hemostasis and you are going to describe the mechanisms in hemostasis, followed by definition of a thrombosis and the different etiopathogenesis mechanisms in thrombosis. And ultimately you will end up with the consequences, or you learn about the fate of thrombus formation. And this is a brief overview of the class, today's class. So, first is an introduction into the hemostasis, followed by the primary hemostatic plug formation, secondary hemostasis. Then we have that which is also called the coagulation cascade, followed by a brief introduction into Virchow's triad, and then we have the thrombosis proper, etiopathogenesis and fate of the thrombus. So, the first one is hemostasis. So, what as you see here in the picture, the bottom one is actually the normal blood flow, and the one on top of that we have the platelet aggregation together. The top two pictures are going to be the platelet plug formation, and then we have the platelet aggregate. Hemostasis is actually a process by which blood clots will form at any site of vascular injury, and generally we have an equilibrium between these procoagulant and anticoagulant factors. Whenever there is a disruption of this balance, you are going to end up with different types of disorders. It could either be a hemorrhagic disorder or it could be a thrombotic disorder. So, as you see in this picture, the first one, picture A depicts a normal hemostasis in balance. So, there is a balance between the procoagulant factors or the forces and anticoagulant forces. If there is a disruption in this balance, if say in B picture you are seeing increase in the anticoagulant forces. In such cases, when there is excessive anticoagulant forces or factors present, you are going to end up with bleeding disorder, which is also called hemorrhagic disorders. And on the other end of the spectrum, on the seesaw, you are seeing the procoagulant forces being higher or more, much more compared to the anticoagulant factors. In such individuals, you are going to end up with the disturbance which is known as thrombotic factors or thrombotic disorders. Another disorder that is to be kept in mind is disseminated intravascular coagulation. This is actually an enigma. You are going to end up with a extensive coagulation initially, and ultimately they will use up all the clotting factors, and this is called consumptive coagulopathy. So, hemostasis is actually a process in which there is blood clot formation, and there are different disorders. First one is hemorrhagic disorders, second one is thrombotic disorders. Another disorder to be kept in mind is DIC, disseminated intravascular coagulation. The different mechanisms of hemostasis, the first and primary one is formation of or the vasoconstriction. Whenever there is an injury to the blood vessel, you are going to have a vasoconstriction that is going to reduce the blood flow to that particular area, and it is going to control the injury. So, what you see in this picture, this is actually a picture taken from Robbins itself. You can see the site of injury, there is a break or the endothelial damage is there, and that is going, there is a reflex vasoconstriction in that particular area. So, the first and foremost step in any injury is going to be vasoconstriction. So, if we finished vasoconstriction, which is the first mechanism of hemostasis, following that the second one is primary hemostasis or hemostatic plug formation, which is also called platelet plug. And the first one is there is exposure of endothelial collagen. Whenever there is a vascular injury or endothelial damage, there is going to be exposure of the subendothelial collagen. This is going to result in platelet adhesion. So, the next step is platelet adhesion that is happening. Along with the platelet adhesion, the next step, the very important one is platelet activation. So, there are two mechanisms in platelet activation which are very important. The first one is there is shape change in the platelet. The normal platelets are generally 8 to 12 femtoliters in size and they are discoid in shape, whereas once they are getting activated, they will have spiculated appearance, and this is going to help in adhesion as well as aggregation. That is the first step in activation of platelets. Along with that, the platelets are going to release some granules like thromboxane A2 and ADP. This is also going to help in platelet aggregation, as you would have studied in chemical mediators of inflammation. Thromboxane A2 is a molecule released from platelets which is going to help in platelet aggregation. So, we have the platelet adhesion with aggregation, and then ultimately you are going to end up with a platelet plug formation. This constitutes primary hemostatic plug. So this is again a picture from the Robbins picture chapter itself. You have the primary hemostasis because of the platelet plug formation, and then we have the secondary hemostasis. So I will deal with that now in detail. So here, when there is an endothelial disruption, you are going to have the subendothelial, or there is tissue factor which are being exposed. Now these tissue factors are going to go and activate clotting factor 7. That is going to initiate the clotting mechanism or the coagulation cascade, and ultimately result in activation of factor 10, which is going to convert. There is conversion of this thrombin, and the activated thrombin or factor 10A is going to convert fibrinogen into fibrin, and ultimately you are end up with a fibrin meshwork, and this together forms the So this is secondary hemostasis, in which there is exposure of the tissue factor. There is because of the tissue factor, it is going to activate factor 7, and activated factor 7 is going to go and convert. Ultimately it is going to result in common pathway activation, that is factor 10 is getting activated, which is going to convert fibrinogen into fibrin, and fibrin will form a fibrin meshwork or a network, and this is going to result in a clot formation or a thrombus formation. So this is a secondary hemostasis. So this is actually a picture of a pictorial depiction of the blood clot. So we have the RBCs and with the fibrin thread and the platelets together. Along with the clotting factor pathway stimulation, you are going to have antithrombotic pathway, or the fibrinolysis pathway is also getting activated, or co-stimulation is also there simultaneously. And the main factors are result of the release of the tissue plasminogen activator, which is going to help in fibrinolysis, and ultimately you are going to break down the fibrin into getting various end products like fibrin degradation end products, or the D-dimer is one such example. So that was a brief introduction about the hemostasis. So hemostasis, to summarize, it is actually a clot formation at the site of vascular injury, and there are various mechanisms. Like the first one is vasoconstriction, second one is platelet plug formation, and the third one is secondary hemostasis plug formation or a coagulation cascade, ultimately resulting in a fibrin meshwork. And always remember that alongside the activation of these pathways, you are also going to have a fibrinolytic pathway as well. So the topic proper, we will start the discussion with a case scenario. It is a 56-year-old female who has been hospitalized for chest discomfort with ECG findings. There were ECG changes, and along with that she developed lung infection. Following that, after 2 weeks later, she has developed painful leg swelling. Painful leg swelling was there, and the swelling was actually tender, but it was not warm. So that means there is actually some injury happening there, and it is tender. So there is pain over there, but it is not warm. So it is not an active infection related inflammation going on. And she later developed, after 3 days, she developed dyspnea, which is of acute onset. So this is a clinical picture. We have her left leg is markedly edematous. This marked tenderness is also, she had marked tenderness, and it is not warm. So the topic proper is actually on thrombosis. So this patient actually developed deep vein thrombosis, and the reason for developing dyspnea is actually because of the pulmonary embolism, which is a complication of this thrombus that has developed. Before moving on to the topic proper, so we had a case scenario. This is one eminent pathologist. He is actually the father of modern pathology, known as Rudolf Virchow. And his contribution to this branch is innumerable. And so the next important topic that we have to cover is Virchow's triad. These are the various factors. So it's a triangle, it's a triad. We have factors which are contributing to the thrombus formation. The first and foremost one is altered blood flow, and the second one is hypercoagulability of the blood, and third one is vessel wall damage. We shall discuss all of them in detail. The first one is altered blood flow. In abnormalities of the blood flow, either there could be a stasis of the blood, or there could be a turbulent blood flow, or hyperviscosity of the blood flow, or the RBCs itself. This is actually the normal blood flow or the circulation. What you are seeing are these are called laminar blood flow. So we have the blood vessel. The two parallel lines are the blood vessel, the cut section of the blood vessels, which are lined by endothelium, and the purple dots represent the cellular constituents of the blood. They are moving in the circle. The motion will be in such a way that the cellular constituents are in the center of the blood vessels. So this is actually a laminar flow, a normal flow. Whereas whenever there is a stasis or a turbulent blood flow, what happens is that the cellular constituents are going to move either to the one lower end or the upper end, anyways to the margin of the blood vessel. So here what happens is that when these cellular constituents are moving to the edges or to the vessel wall, it is going to bring the platelets in contact with the endothelium, and this is going to promote endothelial activation as well as leukocyte adhesion, as what happens in the inflammation condition. And it can also prevent dilution of the activated clotting factors, and it can also retard the inflow of the clotting factor inhibitors. So ultimately what it happens, or it helps us developing a build up of this thrombi itself. So the first factor in altered blood flow is stasis or turbulent blood flow. This picture is actually a gross photograph or the macroscopic appearance of adheroma aorta. So what you see here, it's a cut section of the blood vessel. You can see the vessel is not smooth. There are various bumpy areas are there. So these are actually atheromatous plaques which has ruptured, and there is ulcer formation. So definitely you are not going to find a laminar blood flow over here. It will be a turbulent blood flow. Next picture is actually a PET film smear picture which is showing sickle cells. So again they are also going to have an altered blood flow. Next picture is that of polycythemia rubra vera. It is a condition in which RBC mass itself is elevated. It is a myeloproliferative neoplasm with increase in the RBC mass. Again you are going to have a lot of hyperviscosity issues will be there, or hypercoagulable states will be there. This is actually in rheumatic heart disease, the valve damage is there. Valve stenosis can happen. This can also result in alteration, or the instead of a laminar flow of the blood, you are going to have a turbulent blood flow. This is a picture showing the vegetation of the valve. Again, this is also going to contribute towards a different altered blood flow. The next one is endothelial injury. So we can, if the blood vessel is having any ulceration or ulcerated atherosclerotic plaque which is shown before, or myocardial infarction or deformed valves, these are going to contribute to the endothelial these are different factors of endothelial injury. Similarly, we have various factors which are going to cause endothelial dysfunction like hypertension, hyperlipidemia, homocysteine accumulation, cigarette smoking, radiation, bacterial endotoxins. All of these are going to cause endothelial injury, and we know that once there is an endothelial injury, it is going to expose the subendothelial collagen as well as tissue factor, stimulating the activation of the hemostatic mechanisms. The third one is hypercoagulability. Any alteration in the coagulation pathways that predisposes to thrombosis, and basically the etiology is classified as primary factors or genetic factors and secondary or acquired factors. If there are one or more inherited prothrombotic mutations that can result in thrombosis, and similarly we have a lot of acquired prothrombotic stimuli. Out of all of these, we have factor V laden mutation, prothrombin mutation, MTHFR mutation, increased factor 8, 9, 11, protein C and S deficiency, antithrombin deficiency. And on the acquired end, we have all these conditions which I shall explain in detail. Out of the inherited patterns, the most important ones are factor V laden mutation as well as prothrombin mutation. Factor V laden, it is one of the most common hereditary risk factor for developing of venous thrombosis, and it is present in 2 to 15% of Caucasian population. It is actually caused by a mutant point mutation in factor V. It is called Leiden because it is discovered in a Netherlands city called Leiden. So there is actually a point mutation in factor V. So this makes the factor resistant to the cleavage by protein C. So if protein C is not able to cleave the activated factor V, it will keep on accumulating. So the very first and foremost genetic condition that you have to remember is factor V laden mutation. So here we have the blood flow and the activated factor V is there, factor 8 is also there. What happens is that if there is factor V laden mutation, it is going to make the factor resistant to the cleavage by protein C and protein S. Next mutation is prothrombin gene mutation, and it is the second most common hereditary cause for developing of thrombosis. It is again present in 2% of the Caucasian population. This is also by a point mutation in 3' untranslated region of prothrombin gene, and you are going to find elevated levels of prothrombin in plasma. Next one is antithrombin deficiency. It is actually the molecule which is inhibiting thrombin, that is factor 10A, and other clotting factors. It is the activity is actually enhanced by heparin. The risk factors for venous thrombosis, especially during pregnancy. So this is very important. So, I have told before about the secondary type of hypercoagulable states. These are some of the examples: antiphospholipid antibodies. If a pregnant lady, for example, a pregnant lady is coming with a history of recurrent missed abortions, you will have to think of antiphospholipid antibodies and subsequent clinical tests should be done. The second one is malignancy. Then we have immobilization. A patient who is hospitalized for a long duration, it could be post surgery, it could be because of pregnancy, any factor, the immobilized patient are prone to develop a hypercoagulable state. So, these are called secondary hypercoagulable state and they are going to end up with a thrombus formation. Then if there is hyperestrogenism, hyperhomocystinemia, and the next one is the heparin induced thrombocytopenia. This is a clinical presentation. Whenever a patient is on heparin, sometimes you get the peripheral smears with thrombocytopenia, and once they are off the heparin, you will find normal platelet count. Then we have something called thrombocytosis. One myeloproliferative neoplasm associated with thrombocytosis is essential thrombocythemia. So, these are the various secondary hypercoagulable states. So, to summarize the Virchow's triad, these are the various factors which can contribute to thrombosis. The first and foremost one is altered blood flow. In altered blood flow, we can have either stasis of the blood or we can have turbulent blood flow, or it could be because of the hyperviscosity. Then we have the hypercoagulability of the blood. Again, it can be because of two main factors. It could be genetic or it can be acquired. Genetic factors, the important ones are factor V laden mutation. This is a point mutation. And then we have prothrombin gene mutation and then antithrombin 3, the activity of that. Apart from that, acquired conditions include hyperimmobilization, antiphospholipid antibody syndrome, then hyperestrogenic conditions, heparin induced thrombocytopenia, etc. The last one is vessel wall damage. So, there are various factors which will result in endothelial damage and they are going to start or stimulate thrombus formation. So, this is about Virchow's triad. So, the very important topic next is thrombosis, the definition of thrombosis. It is actually the process of formation of solid mass in circulation from constituents of the flowing blood itself. So, there is actually a solid mass formation within the circulation and that mass is actually formed by the cellular constituents from the blood itself. This definition is very important. It can occur anywhere in the cardiovascular system. It can be in the cardiac chamber, it can be from the valves, arteries, veins, capillaries. The shape and size of these thrombi can vary, and one important thing is that it is going to be attached to the vascular surface. So, thrombosis, it is actually defined as a process in which there is formation of solid mass in the circulation from the constituents of the flowing blood itself. This is a macroscopic picture of a thrombus formation within the blood. So, here it is not the blood vessel, it is just the thrombus taken from the circulation. This is a microscopic picture. So, this is actually a photomicrograph from lung. So, the periphery what you see are the alveoli and there is a blood vessel which is filled with a thrombus. So, this is what a picture of a thrombus or a microscopic picture of a thrombus in lung, pulmonary circulation. Very important finding that is seen in microscopy is something called as lines of sand. So, you are going to, when there is a flowing blood, thrombus is basically a solid mass formed in the flowing blood. So, you are going to have deposition of these platelet and fibrin along with the cellular constituents along with like RBCs, and there will be a laminated architecture or an alteration between these formation deposits. So, you are going to end up with a pale area which is actually formed by platelets and the fibrin, and we have a dark or denser red cell rich area. So, you are going to have a dark area over there. So, there is an alternating pale and a dark red area. So, together like that there are many laminations or different layers of it. This is called lines of sand. This is importantly an important finding seen in the thrombus. Now, there are various types of thrombi. The first difference is between arterial thrombi and a venous thrombi. Arterial thrombi is seen in heart as well as artery, and here you are going to have a rapid blood flow. Whereas, so the main examples are coronary arteries followed by cerebral artery and femoral artery in that particular order. So, first and foremost you are going to find it in coronary artery followed by cerebral artery. This is the incidence, and then femoral artery. And the main etiology will be the endothelial injury itself, and it is going to result in occlusion, or it is going to result in an occlusive type of damage. And important thing to note that is that it is going to grow in a retrograde fashion. And appearance in the microscopy, it is going to look as grey white in color, and very importantly, like the previous slide, you are going to find lines of sand. Venous thrombi, when the thrombi is forming within the blood, within the vessels, the veins itself, here you are going to have the slow flow in the veins and you are going to develop venous thrombi there. And these are the different veins in which you are going to find the venous thrombi: superficial varicose veins, popliteal vein, femoral vein, and iliac vein. So, the main etiology behind the venous thrombi is venous stasis, whereas in arterial thrombi it is because of the endothelial injury. This is very important to know the differences there. And venous thrombi itself can be because there could be occlusive nature or a cast formation, and here you are going to have the venous thrombi developing in the direction of the blood flow, whereas in arterial thrombi it is growing in a retrograde fashion. Here appearance grossly it can have a red blue color, and you are going to have, instead of a lines of sand with pale and red areas, here you are going to find more and more RBCs. This is a picture of a deep vein thrombosis. So, in the deep veins, whenever there is a stasis of blood, you are going to end up with a thrombus formation, and later on they can, I said in the previous slide that there is going to be an attachment to the vessel wall. When once it is propagating, later on a small portion of the same thrombus can get detached, and this forms the embolus. So, we talked about arterial thrombi, we talked about the venous thrombi. The next one is mural thrombi. When the thrombus formation is happening in the cardiac muscle or the cardiac chambers. So, there is because of abnormal cardiac myocardial contraction or endomyocardial injury. And the next one is in the aorta. So, aortic thrombus may be because of an atherosclerotic plaque or an aneurysm. In the heart valve or thrombi which are developing on the heart valve, it could be because of the vegetations, like in case of infective endocarditis, non-bacterial thromboendocarditis, or even Lippmann-Sachs endocarditis. So, another important difference that you have to know is the difference between antemortem clot and a postmortem clot, or the thrombus and a postmortem clot. In thrombus it is going to be firm and dry in consistency, whereas postmortem clot is going to have a soft gelatinous appearance or a consistency. Thrombus is going to be adherent to the vessel wall, whereas postmortem clots are not generally firmly adherent or attached to the blood vessel wall. Thrombus, you are always going to find the development of lines of sand because of the alternative layer of platelet and fibrin along with the deeply RBC rich dark areas. So, there is that alteration of these or laminated appearance will be seen, that is called lines of sand in thrombus, which is going to be absent in postmortem clot. Here instead you are going to find something called chicken fat appearance, because in this postmortem clot the superficial surface is going to be pale yellowish in color and it is gelatinous in consistency, whereas the deep attached area is going to be hemorrhagic, or the dependent area is going to be red in color, which is called red currant jelly appearance. This is actually a gross picture of the postmortem clot. So, the superficial part or the top portion is going to be the gelatinous yellowish area, which is called the chicken fat appearance, and we have the bottom or dependent area which is having a dark red color, which is called red currant jelly appearance. So, we discussed about the thrombus, definition of the thrombus and different types of thrombus. And the last one is fate of thrombus. So, a thrombus which is formed can undergo 4 different mechanisms, or the fate, this sequelae of the thrombus. Either it can propagate, it can keep on developing. So, this is called propagation. The next one is embolization. A small portion of it can get detached and can go to different areas, which is called embolization. Or what can happen is dissolution, complete dissolution of the thrombus can happen. The last one is it can just get organized into the blood vessel wall, or there could be a formation of a recanalization, or new lumina formation can happen within the thrombus itself. So, this is a pictorial depiction of the same. In this picture we have the iliac vein which is having a thrombus. So, the completely occluded thrombus is happening, this is seen in the iliac vein in the cut section. The first picture what you see is propagation towards the heart. So, the thrombus is keep on, there will be accumulation of these cellular constituents, and it is going to keep on increasing and it is going to go to propagate towards the heart. That is the first one. Then on the picture on the lower portion you are going to find something called resolution. It is getting completely resolved. So, there is no thrombus formation, or the thrombus is completely getting resolved there. Then we have embolization, like in the previous picture. Deep vein thrombosis can ultimately result in pulmonary embolism in some individuals. So, it can get embolized, a small portion from the propagated thrombus can get detached and it can go into the circulation, it will go and bind to some other, it will go and get deposited in some other smaller blood vessels. If it is in the pulmonary system, it is called pulmonary embolism. So, in such cases they are going to develop dyspnea on exertion or dyspnea proper, and it is very fatal. And the last one is it can get incorporated into the blood vessel wall itself, and later you can also have this organization and then recanalization, new lumina formation, and it will get organized or incorporated into the blood vessel wall. So, these are the fate of thrombus. The clinical correlations. Whenever we have superficial thrombi in the leg veins, there will be local congestion and swelling, pain and tenderness may or may not be there. So, they are rarely going to embolize. So, superficial veins, you are going to have all these findings, congestion, swelling, tenderness and pain, but they are never going to or rarely going to embolize. Whereas deep thrombi in the larger leg veins are more likely, especially those above the knee, are likely to get embolized. The deep vein thrombi is asymptomatic in 50% of the affected patients. There is another condition called as migratory thrombophlebitis. This is associated with disseminated cancers. So, whenever you have a venous thrombus in disseminated cancers, especially in case of pancreatic neoplasm or breast carcinoma, this is called migratory thrombophlebitis. In arterial thrombi, you are going to have ischemic necrosis and gangrene of the affected part. The artery which is supplying that particular tissue is getting occluded by the thrombus. So, that means the tissue which is getting nutrients from that artery is not going to get it. So, that means they are going to have ischemic necrosis and ultimately death of the cell will happen. Cardiac thrombi, because of the mechanical there will be sudden death by mechanical obstruction or there will be thromboembolism. So, these are the various clinical correlations of a thrombi. So, to summarize, we dealt with hemostasis. Hemostasis means there is a blood clot formation whenever there is a vascular injury, and generally there is a balance between procoagulant forces and anticoagulant forces. Whenever there is a disbalance or a disequilibrium between them, you are going to end up with different types of disorders like hemorrhagic disorders or a thrombotic disorder. Then we have the primary and secondary hemostasis mechanisms. The primary hemostatic plug is formed by the platelet. So, this is called platelet plug formation. And then we have the secondary hemostasis by the activation of coagulation factors or the coagulation cascade. Ultimately, the end product is the fibrin meshwork or the thrombus blood clot formation will happen. Thrombosis is a process in which there is a solid mass forming from the cellular constituents in the blood itself, and this is going to happen only in a flowing blood. So, that is very important to make a distinction between antemortem clot and a postmortem clot. And the important etiological factors responsible for thrombus formation is Virchow's triad. So, it is a triad, so that means there are 3 elements in it. The first one is endothelial injury. So, there is a endothelial or vessel wall damage, altered blood flow will be there, and then hypercoagulable states. Always remember, Virchow's triad is having 3 constituents like endothelial vessel wall or vessel wall damage with altered blood flow or hypercoagulable states. And the fate of thrombi, like I have said before, it could either propagate or it could resolve, it could get embolized to different sites, or it can get organized and then incorporated into the vessel wall itself. So, this is my reference. Thank you for your attention.